Trying to find the right package of care for someone can be tricky. Many people find that they're passed from pillar to post as different agencies, departments and teams assess their needs. But in Taunton, in Somerset, they're piloting a very different approach, using an integrated team who take time to find the right, often small solutions, which will help people regain their independence. Claire Walker went to see how it works with Anne Anderson, Deputy Director for Strategic Development for NHS Somerset.
In the past, we've had lots of services, a range of services, but they haven't always been as joined up as they could have been. And sometimes people fall between services and don't get a service at all. What's happened with the pilot in Somerset is that we've stepped back and we've tried to redesign a new service around the needs of each individual so that we can make sure we have the right support at the right time for each person. So what we have started to do, we've brought together people into integrated teams. So that includes adult social care social workers, health occupational therapists, physiotherapists, and also carers, all working within a team quickly, responsively when they need it.
So what would normally happen would be you would have these separate teams who wouldn't necessarily speak to each other, is that right?
Yes, so we'd have separate teams who try very hard to work together, but when you're working within teams and in organisations, there's lots of systems that get in the way, and people are working very hard in those teams to try to work together, but it is difficult. And the staff in these new teams say that it's so much better working together in a much more integrated way, joining up the cultures, removing the barriers and the constraints and making it much easier for them to work around what really matters, which is the needs of the patient or the service user.
One of the most recent people to benefit from this new way of working is 78-year-old Ralph Bale. A week ago, he hurt his knee, spent 5 days in bed resting, and as a result developed a chest infection. Sue Glanfield works on the health side of the pilot project and took me to visit him at his home in Taunton.
I fell out of bed and damaged the knee and spent a long time in the hospital for an x-ray and they discovered I had a chest infection. They sent me home again and my GP said he was going to try a new type package of care. They assessed me and allocated carers to come and get me up in the morning and come and put me to bed at night. In my case, it's a win-win situation because I'm getting the finest care I can have. I'm in my own GP's care, and well, what could be better? Being in your home environment. I didn't really want to be in hospital.
Why was it important to you that you stayed in your home and were able to be with your wife as well?
Because I can do my thing. I do all the medication orders and all that on computers. And shopping as well. Online shopping.
So you're a whiz at the computer, you shop online?
Yes, definitely, yep.
So you wouldn't have been able to do that and keep the food in the house for your wife if you'd been in hospital, is that your worry?
Yeah. We're getting on quite well together and I can support her and she supports me.
So Sue, in terms of Ralph getting this care, why is this different from what he might normally have received?
Normally, Ralph would have presented as being quite unwell. He'd developed a chest infection by being in bed. He had the pain in his leg and was also, with his diabetes, beginning to struggle with that as well. So he had an increasing number of health problems that very quickly could have looked like he needed to be in hospital. If social care had been able to come out very rapidly, they would have been concerned about whether he was well enough to be managed at home. The care workers coming in may have struggled to know how best to help Ralph to move around. He's had a stroke, which is still affecting his right side of his body, and he moves in a very different way to how other people may move, and so they needed to know exactly how to help him.
So really, in the past where you would have had these separate teams, now you have one team that's dealing with it all at one time.
That's right, yes. It's one integrated team where we've got the skills and the knowledge across all those organisations and all those people that can all pool in together to come up with the best plan possible that's right for Ralph, that's going to get him back on on his feet. Carers will often come back to the team and say, actually, Mr. So-and-so, he's getting on much better now, he doesn't need my help with. And the package can be much more flexible, much more responsive. We're trying to get away from people being dependent on packages for a long term. Historically, the way that we've looked at providing packages of care, it's been often around time limits, and the carer has a specific amount of time in which they need to complete a number of tasks. Often thinking about supporting someone to be able to do something for themselves hasn't been, therefore, the primary focus. The way that the teams are now working is about what's important to somebody, how can we support them to regain their independence? And the focus is giving them the right amount of time to help them to do it for themselves, rather than to provide the care and do it for somebody, because they're never going to learn their independence then. They're never going to be supported to manage without that care. And most people want to be doing things for themselves and not have a care package.
So it makes them less dependent.
That's right. Ralph's goal, he said to us on that first appointment, was to be able to get back out into his car and drive and be able to take his wife out. That's where the team are heading. So although at the moment it's about supporting him to be able to get up, get downstairs in the morning, ultimately that's the goal.
And this incident, Ralph, it only happened a week ago.
Yeah.
And already you're looking bonny, I have to say.
Yeah, I'm feeling quite good. And I can see the light at the end of the tunnel, and it's getting brighter by the day.
Why is it important to you to be able to get back in your car?
Well, it's one of those things. I don't feel any good to my wife unless I can take her places. And, convenience. That's what it's all about. I know I'm a young 78-year-old, but a mate of mine who died last year at 92, he was still driving. So I won't be the same.
I think what this service does is try to be more creative and look at solutions that are unique and ideal for that individual person, rather than try to make them fit into all the resources that we've got.
Fred Parkin leads the adult social care side of the project. She explained to me why this flexible way of working helped her team find a solution for an older gentleman who was caring for his wife.
Traditionally, we would have put a care worker into the home, but his wife, who had dementia, found that really difficult and became very distressed when that happened. So what we did was we looked at how we could support them to go into town independently, how he could use his scooter, and eventually got them going to the local department store for their lunches, as they always had done. And that was a real success story.
So how did you do that?
Well, first of all, we had to uncover what the real problem was. It wasn't just about enabling them to eat. It was about actually they needed some social interaction. Part of their routine was to get out every day, and the physio and the occupational therapist actually went with them to the department store and actually helped them with the scooter and how to get the access to the department store. And that took a bit of time, but it was worth it because now they're independent.
So they helped them plan the route in and showed them how to do it?
Yes, exactly.
And it's simple, isn't it?
It is simple, yes, it's simple, but that sort of thing takes a lot of time, and due to the demand on the services previously, we haven't been able to respond to that.
But is this service costing more money? Anne Anderson again.
These aren't new teams over and above what's there existing. This is about redesigning what we've currently got to make it work better. So it is costing us a little bit more money up front because we're spending a little bit more time understanding what the real issues are. But what we're seeing already is that if we get it right first time, then it's costing us less down the line, and also the outcomes for the service user are so much better. It's reducing the readmissions to hospital and reducing the admissions to long-term care as well. And people don't want to go into long-term care, they want to stay in their own homes.
So far, the team has seen 750 people since May, but they hope to roll this out across the county and treat 4,000 in the next year.
We've piloted it because we needed to learn, and without a doubt we've had to take a step of faith. We've got an ageing population, we know the demand is going to be more, and we know that we're unlikely to get any more funding. So we've taken that leap of faith, and the initial signs are very positive, and they're positive enough for us to want to spread this further and to continue to test this different way of working.
Claire Walker reporting. Well, the man behind the thinking they've been using in Somerset is Professor John Seddon. He's an occupational psychologist, but also managing director of Vanguard, a consultancy company that redesigns service organisations, both public and private, from the customer's perspective. He joins us from Oxford. Professor, good afternoon.
Good afternoon.
It seems so obvious, doesn't it? You look at a person's needs and build a package from there.
Yes.
Why doesn't it happen more often?
I suppose three broad reasons. Our health and care services are subject to compliance with central government specifications and directives. I mean, you heard Anne say that, there are many different functions. It's the same in both health and the local authority. And now those functions are also running to activity targets that have to report to the centre. Also, the current wave is for commissioning. So these are all things that are coming out of the centre. The second broad reason is this is a challenge to conventional management. Conventional management focuses on costs. So, for example, in local authorities, we see something called fair access to care services, which means if you've got low or moderate needs, we won't help you. And commissioning is all about trying to manage cost. And central government believes in industrialisation. The bigger is better. So we front-end these organisations with call centres conventionally. And third big reason is that this change, and here I disagree with Anne Anderson, is not a leap of faith, because it starts with studying, getting knowledge, and the most important thing that they've been studying is understanding the true demand from the client's point of view, and the context. What do these people actually need to live a good life? And this is not a change that starts top down from Whitehall or anywhere else with a plan. This is a change that starts by studying, and then the redesign is emergent.
Do you accept, though, the point that she made, that at least in the short term it will cost more?
Well, no, not really. I mean, I'm surprised, because that's kind of a conventional view. Because we're taking a bit more time, it will cost more. No. What you actually see going on. I mean, she made this point herself, is that because we don't attend to people's needs, we drive them into care homes. Because we don't attend to people's needs, we admit them into hospital. For example, in the Northwest, where we've got a similar scheme running, we've actually found that hospital admissions have fallen by as much as 30%. And similar numbers in people not being driven into care homes. So the true cost of a service is end-to-end. So while we might be spending a bit more time up front, the end-to-end costs are dropping out dramatically.
She talked about the rollout across the county of Somerset.
Yeah.
If this model were followed more widely beyond Somerset, we're talking, aren't we, about major reform and a major rethink of the way we actually run this whole sector. Do you think there is the stomach for that just now?
Well, you'd hope so, wouldn't you? I mean, the evidence is...
You might hope so, but do you think there is?
Is there a stomach for doing things on the basis of evidence in Whitehall? That's an interesting question. But however, what you can't deny is that what we're finding, for example, in the Northwest, is that this is improving the service, and the costs are falling by as much as 25%.
And that's perhaps the most potent argument you have here, isn't it? Because at a time when budgets are so stretched, if you can make the argument on economic grounds, you might stand a greater chance of getting it through.
Well, that's exactly right, Julian. But, the interesting thing is that Whitehall is not very good at responding to evidence. John Kay, the economist, talks about this. He says that Whitehall is about policy-based evidence. In other words, the minister has a policy, how many people comply, that's evidence. And when you feed evidence like this about care services, I have been doing now for about 7 years into Whitehall, evidence gets sort of measured down to be just another opinion by the time it gets into, the hands of the ministers and their civil servants.
Well, we may well hear from a minister or indeed a civil servant on this subject to see what they think. But thank you very much for coming on the programme.
My pleasure.
Professor John Seddon joining us from Oxford.